Hello, my name is Brittany Klenzar, and today I will be presenting on the HIV Support Program Evaluation Report. So first, why focus on HIV? Currently, there is no cure for HIV, and it seriously weakens a person's immune system, leaving the body vulnerable to everyday infections that could prove to be fatal. If left untreated, HIV can significantly damage the body's immune system, resulting in the onset of acquired immune deficiency syndrome, or AIDS. There are several risk factors associated with contracting HIV, and these risk factors include having unprotected vaginal or anal sex, sharing needles or syringes, and through the breast milk of an infected mother. In Clark County, Nevada, there's actually a higher prevalence than the national average of HIV incidences, and this is 21.5 versus 11.9 per 100,000. And even in Clark County, there's more of a disproportionately burdened group, as 59.9 per 100,000 African Americans get HIV compared to only 14.2 of their white or Caucasian counterparts, as seen in this graph on the right here. So after obtaining the information from the needs assessment, stakeholder input was sought out, and we spoke with an individual in End HIV Nevada who shared with us that 13 to 24-year-olds account for 16% of new HIV diagnoses. Nevada rates 18th in the nation for new HIV cases. And a lot of this may be attributed to the fact that there's a lack of comprehensive education in Nevada, and that's a serious barrier for prevention. And there's also legislation that forbids distribution of condoms in schools. So one of the community partners, the Southern Nevada Health District, goes in and gives presentations in school districts and actually needs to obtain all the condoms that are administered during that presentation. So one positive is that individuals as young as 12 can get free HIV testing without consent of a parent. And this is definitely an advantage. And lastly, the further away an individual is from metropolitan area, the less resources they have about sex education. And this kind of led us towards a more mobile-based platform for our intervention, especially among young people who regularly use technology. So when designing this intervention, it was important to implement best practices, and these were identified in a systematic review where it was included that the program should be theory-based, web-connected, and appropriately separated for the target population. Next, it was important to consider that Black and African Americans represent more than 50% of new HIV infection, with male-to-male sexual contact being the primary mode of transmission for individuals over 13 years old. This is also reflected even in Clark County. And lastly, that school districts in Nevada would not be feasible due to the legislative restraints, and administering contraceptives wouldn't be permitted. So with that, we implemented the MyPeeps mobile-based application. This is designed to target a person's personal attributes, family context, peer and partner relationships, and environmental circumstances that are associated with HIV. So this has been shown to have an effective increase in biomedical approaches for prevention and treatment, such as pre-exposure prophylaxis and post-exposure prophylaxis, increases in sexual health knowledge, the consequences of sexual risk behaviors such as substance use, and how to cope with minority-related stresses of one's sexual identity. So another strong component of the MyPeeps intervention is that the in-person version is actually included in the CDC's archive of evidence-based intervention. And because MyPeeps was specifically designed for young men who have sex with men, no adaptations were implemented into the learning modules, as this is the target population of the program. So to go over the evaluation design, it will be split into 3 conditions. Condition 1 being those who receive HIV toolkits. So young men that have sex with men in this group receive condoms, an informational pamphlet on where to receive PrEP and PEP, and an at-home HIV test. The next would be those who receive MyPeeps, which, as previously mentioned, is the mobile application. And the third would be those that receive HIV toolkits and the MyPeeps, so a combination of both resources and education. So as seen in the right-hand corner, this would be the inclusion criteria. 180 individuals actually completed the HSP program, but 17 were excluded because they didn't meet this criteria. So next I want to go over the demographics of the HSP program. So as you can see here, it was a pretty diverse group, with 26.38% being Hispanic, 23.81% being non-Hispanic Black, and we really wanted to capture more minority groups because they're disproportionately burdened by HIV. Next is the percentage of participants by age. So the age ranges from 12 to 19, as this accounts for 16% of the new cases. And these individuals are not receiving comprehensive sex education in Nevada, so it's important that they were targeted. Just to reiterate the evaluation design, so a non-equivalent group design was utilized for this, And this was favored as the results will be able to guide future efforts as to whether they should provide resources such as the HIV prevention kits, education as can be found in the MyPeeps, or a combination of the two to prevent HIV. As seen here is the logic model. So this is going to represent the resources that's going to be needed for the program, the activities, who will be participating, and with all this, the outcomes that are expected. So first, there will be an increase in self-efficacy, and this could result as a outcome of the MyPeeps program. There will be an increase in knowledge in HIV and sexual health, of risk behaviors such as alcohol and substance use, and skills to manage stigma, and an increase in willingness to use PrEP and PEP. This will lead to behavioral changes such as condom usage, decreased drug and alcohol usage, an increase in HIV testing, especially because we were providing the HIV test kits, and uptake of PrEP and PEP usage, and less sexual partners, which will lead to conditional changes such as improved social conditions through the elimination of disparities that are associated with HIV, less social stigma, an overall reduction of sexual partners, which will eventually and hopefully lead to less incidence of HIV among YMSM. So just to reiterate the HSP timeline, first, the evaluation team will administer the guidelines and program activities to the community partners. The community liaisons with the LGBTQ Center will onboard participants to the platform and obtain addresses to receive the HIV toolkits. And they were identified as a community partner because when we had spoke with the stakeholder at NHIB Nevada, they had mentioned that they host youth advisory boards, so they had direct access to the target population. And at this time, while they're onboarding the individuals, they will complete a pre-survey that's going to be designed to kind of assess their knowledge and behaviors. Next, the test kits in June and July, the test kits will be received by individuals in those conditions, and modules be completed to those assigned to the MyPeeps conditions. And at the 3-month follow-up, the survey will be administered to assess any changes that it may have resulted from the HSP timeline. So just to provide a background on the program, so for MyPeeps, social personal model is kind of the theoretical model that underlies that program. So this is based on social learning theory, and this theory recognizes the integral role of one's personal attributes, their family context, their peer and partner relationships, and environmental circumstances. So that's why the information on the application is aimed to impact self-efficacy, behaviors, and knowledge. So the health belief model can actually be used to help explain initiation of HIV preventative behaviors. So research indicates that engaging in a health promotion behavior can be explained to the degree that an individual recognizes the benefits of action. So in this case, that's avoiding risk behaviors, using condoms, and getting tested for HIV. Also, it addresses the barriers and possibly perceived risk of an individual contracting HIV. And for those using the MyPeeps app, a cue to action will be triggered, which will increase the likelihood that the HIV prevention resources received will be utilized. And for those receiving just the toolkits, the perceived barriers will be lessened as the program participants will no longer face the barrier of having to obtain contraceptives or HIV test kits, and these will be provided for them. And then also I wanted to mention that the health belief model has actually been cited as an appropriate model to explain HIV testing. So to assess all of this, there were 2 evaluation measures that were conducted. First is process evaluation, and this was utilized the RQFSM model to measure how many participants were reached, were the resources adequate to support program delivery, were the project activities delivered as planned, did participants actually utilize all the resources, and were the resources used efficiently. So here's the data analysis for the process evaluation. The first one being that the UNLV team will administer the prescribed guidelines, and this goal was met. The next would be that the community liaisons at the LGBTQ Center will have 60 young men and have 6 men onboarded onto the MyPeeps platform, and will obtain 60 addresses for them to administer the preventative resources, and this was also met. The only process evaluation goal that was not met was that 60% of MyPeeps users would complete all assigned modules assigned to them. And as you can see on the graph on the right-hand side, only 52% of participants completed more than 60% of the assigned MyPeeps modules. So they actually didn't utilize all the resources that were given to them. Next, outcome evaluation is going to be conducted as well. So that assesses if the material presented to them actually increased knowledge on HIV transmission and prevention, if they were able to demonstrate more behavioral skills as a result, if they use, such as using condoms more frequently, and did they have a decrease in substance use or an increase in self-efficacy post-program. So the outcome evaluation measurements that were used can be seen in the graph here, such as questions that were asked were, in the previous 10 sexual encounters, how many times did you use a condom? How in the past 30 days, how many times did you use alcohol or drugs? Can they actually explain how PrEP prevents infection, how PEP impacts infection? And this was assigned to determine their HIV knowledge of transmission and prevention. And you can also see here in the content of the HIV KQ questionnaire. And so this was given to assess whether or not they can answer true or false on HIV related questions that assess knowledge. So here are the data analysis for the outcome evaluation that was conducted. So the first two goals were assigned to actually assess condom usage. So the first one being, do those who receive contraceptives only report an increase in condom usage? So this goal was met, as you can see in the KITS group. So the other two is MyPeeps, that's going to be knowledge only, and KITS and MyPeeps, that's knowledge and resources. So the first bar here, you can see it pre-HSP program to post-HSP program, there was an increase in condom usage, suggesting that the resources were really helpful for those who obtained them. The next was that those who completed the MyPeeps program and received HIV prevention packets will report an increase on surveys compared to those who had knowledge only and maybe just the prevention only. So as you can see in the third column, those who received both knowledge and resources had an increase, but those who had just knowledge only did not receive any increase. Next was designed to assess for those who completed the MyPeeps modules if they would report an increase in knowledge about HIV transmission and prevention immediately following the curriculum. And as seen here, the darker graph being pre-program, the lighter graph being post-program, and the axis showing the score that was summed for the HIV KQ that was previously mentioned. Those at post-program actually did report an increase of their score on the transmission and prevention of knowledge. And then lastly, if those who completed the MyPeeps program and received prevention packets report higher on the knowledge/awareness survey of HIV/AIDS transmission and prevention than participants in the comparison group. So this goal was not met, as those who received KITS and MyPeeps didn't show the highest change in score. So the only good thing about this goal was that those who did receive just MyPeeps showed an increase in knowledge score following the program, as the post-HSP is the lighter color. So while the resources didn't actually contribute to their knowledge score, there is promise for the MyPeeps program, as their scores did increase. So just to go over the findings as well, as seen in the graph on the left-hand side, individuals past 30-day alcohol usage was also assessed and talked about in the MyPeeps program. And as you can see on the left-hand side of the graph, with the lighter end being post-alcohol usage, 0 to 5 day usage actually increased. And as you can see in the 26 to 30 days, the 26 to 30 day decreased by the end, which means they were using alcohol less by the end of the program, which was really great to see. It was also successful at increasing knowledge of HIV prevention and transmission, as was seen as the individuals who completed the MyPeeps modules demonstrated the highest HIV KQ scores. Really, this program emphasized the need to provide access to resources. So the knowledge was a great component, but the thing that actually dictated behavioral change was receiving those resources. And I think the fact that this had presented both a knowledge change and a resource or a behavioral change through resources, really emphasizing that participants really should be receiving the MyPeeps app and resources in tandem if they want both changes in knowledge and behaviors. So limitations of the study, one is to expand outreach efforts. So those who may feel the most stigmatized or needs resources may not be receiving help at the LGBTQ Center. So our study limits generalizability, as it was only assessing those who are seeking help at the LGBTQ Center in Las Vegas, and they may have a specific set of demographics about them that can't be generalized to everybody else. Next is the 60% adherence. So as mentioned, the process evaluation, the module adherence lingers at 60%, and this could also explain the limitations in the MyPeeps ability to influence PrEP and PEP willingness, as we did not see any change in the willingness to use these post-program. There was no change in drug usage either, and this may be from the fact that the modules were not completed, and also the fact that condom usage wasn't influenced by MyPeeps. So future directions to maybe reframe the information on PrEP and PEP, collect any sort of participant feedback as to why adherence was low. And additionally, something that was noted throughout the program was that there was a significant amount of alcohol and drug misuse among a very young population. And although this wasn't the aim of the study, it really highlights the need to focus or expand efforts to substance use as well. And next, this information should be utilized for information on legislative constraints in Nevada. So for example, the fact that a comprehensive sex education program such as MyPeeps was effective at increasing transmission and prevention knowledge of HIV, and that providing resources to adolescents is key if we're looking for behavioral change to use condom and stop HIV incidents. So thank you for your time.